What we need is not more medication, but more education, because the best prescription is knowledge. This is Exposé coming to you live from Lagos, Nigeria, every Monday on Instagram, YouTube, and Facebook simultaneously. I'm the regular host, Tony Akinyemi. Don't forget, what we need is not more medication, but more education, because the best prescription is knowledge. Hello and welcome to Exposé with Tony Akinyemi this beautiful Monday evening, 8 p.m. West African time. It's always an honor to be your host on this program. In this particular series, we've been talking about fertility, infertility, and we are now zeroing in on maternal mortality. That is when mothers die either before they deliver their babies or during delivery of their babies or up to 6 weeks after delivery of their babies due to pregnancy-induced complications or birth complications, or sometimes underlying medical conditions aggravated by pregnancy, thereby leading to death. We've had the honor of hosting Dr. Kemi Akindele, a consultant gynecologist, obstetrician, and a public health physician on this platform. Last week was a blast, and today we want to continue the conversation again. So, Dr. Akindele, we welcome you to Exposé with Tony Akinyemi today.
Thank you so much. I'm happy to be here.
Right. Without taking much time, I want us to dive in right away. But let me just give a little background to what we discussed last week for those who might be joining us for the first time. You helped us to understand what maternal mortality is all about. You also reeled out some very, very concerning statistics, particularly concerning how many women die due to pregnancy and childbirth in sub-Saharan Africa and in Nigeria in particular. And we saw what the figures were for the USA, for the UK, and for Canada. And that of Africa is not beautiful at all. And you also helped us to understand some of the factors that could be responsible. It could be as a result of the fact that they don't have access to proper care. It could also be economic in nature. It could be as a result of malnutrition. It could be as a result of ignorance. It could be as a result of the fact that there are not too many trained personnel, a lot of quackery going on here and there. All of these things can contribute to those very horrible statistics. And then we looked at factors that could contribute to maternal mortality, mothers dying due to pregnancy-related matters. And you helped us to categorize those factors into 5, if I recollect. The first one, you talked about abortion-related, death, either due to spontaneous abortion or due to ectopic pregnancy or due to, improper approaches to abortion. You mentioned hemorrhaging, postpartum hemorrhaging. You mentioned hypertension-related issues, preeclampsia and what have you. You also mentioned issues of embolism and then, of course, infection. Those were the 5 categories, if I recollect. So we want to take off from there. Last week, you spoke extensively to us on the first 2, abortion and hemorrhaging. Today, we want to start with hypertension-related complications, eclampsia, preeclampsia, and all of those things. Please, the floor is yours. Just go ahead and begin to lecture us.
Thank you. Thank you so much. So, interestingly, hypertension related causes of maternal death was one of the things that spurred the antenatal care, that started the people to reason that, look, if we care for women before pregnancy, possibly we're going to save some, because in those days they didn't have care before pregnancy. They just noticed that some women start to convulse, they convulse and they die. And so they started looking at why would a woman convulse, and research then showed that before a woman convulses, most of them will have high blood pressure, they will have protein in the urine, and then they had some conditions about like headache, oh, I'm not seeing well, and all that. And then the next thing, they've convulsed, they're dead. And when it was discovered that hypertension could lead to that, then came the word eclampsia is a woman who convulses, you know. A woman is pregnant, she's just had a baby. So there are two categories. They could convulse before delivering the babies, while delivering the babies, or afterwards. And it's all linked to hypertension and protein in the urine. So preeclampsia would present when a woman goes for prenatal care. Now, what we do routinely is to check the blood pressure and the urine. And one of the things you are looking for is this, because when that process starts, we don't know how it ends. It's a multi-organ thing, and sometimes it goes really fast. So even in developed countries, it's one of those things that still kill women because of the fact that it could just happen like a flash.
Right.
So hypertension would be any blood pressure above 140/90, 140 systolic over 90 diastolic, and proteinuria would be at least 2+ proteinuria. We look at trace and plus. Now, I'm giving this background so that we know that hypertensive disorders of pregnancy is sometimes not preventable from happening, but we can prevent maternal death from it. If we have a good surveillance system and we take things up immediately, then we can prevent maternal death. We can prevent eclampsia itself, which is, you know, really a risk to the mother, and we can prevent maternal death. Now, as a cause of maternal death, I saw it so many times in Nigeria that a woman was brought in convulsing, and many times the baby is dead, and the mother has, even if they don't die, many come out with real morbidities, like they had a stroke and then become paralyzed on one side and all that. And that's what they have to bear through the rest of their lives, because they went through this horrible event. Yeah, so I think have I given a good overview of hypertensive disorders of pregnancy? Yes. So when hypertension is peak, and it's more common. So let me talk about how it's more common in women who are pregnant for the first time.
Okay.
Women who are pregnant for the first time for another partner. Oh. Women who have hypertensive disorders to start with. They started out with hypertension, then they have on top of that preeclampsia.
Okay.
And yeah, so those are the ones in which we find it more commonly. Of course, it can happen randomly, but those are the most important things to note.
Now, you raised a point that is a little bit puzzling. What would account for a woman who is having a second pregnancy before another man? Why would she be prone to preeclampsia or eclampsia?
So preeclampsia is one of those conditions where it's kind of difficult to know why, but this is what we see, right? This is more common. Okay. It's what we see. So it's almost like the woman is getting pregnant for the first time. The other one I didn't mention is for women who have very long, like, a woman has had a baby as a teenager, and then now the next pregnancy is 10 years later. It's still common in them too. Exactly. So again, it has to do with also maternal age. It's more common amongst women who have their first baby late. 35 years, first baby. So those are some of the things that are more common in them.
Now, what would be your advice, for example, for a couple if the woman is an established hypertensive patient and they still want to have a child? What would be your advice for them before they go into pregnancy?
It's very possible to achieve a very good pregnancy, but go see your doctor first. So one of the things that happen with preeclampsia and hypertensive diseases is multi-organ damage. The kidneys could be affected, the liver could be affected, the blood clotting system could be affected. Of course, there could be stroke and all that. So you want to be sure how all these things are functioning before you get pregnant. You want to switch from the antihypertensive drugs you are on, if it's not compatible with pregnancy, because there are some that are not, that you have to stop and switch. You want to be sure that. Also, we talk of low dose aspirin now to prevent, in some women who've had preeclampsia before, when they get pregnant again, low dose aspirin has been found to help in preventing the complications of hypertension with next pregnancy. So you want to be sure you consider yourself high risk. That's not by confession. It's just that that's how it is. So you go see a doctor and get proper treatment and get ready to get pregnant. And then, of course, the follow-up is more intense to make sure things just don't go bad fast.
Okay, let me ask you, you're speaking to a laywoman now, layman, okay? And she says, look, madam, I want to get pregnant. What preparations should I make generally before pregnancy? And then when I am pregnant, in order to care for myself and my unborn baby, what are the tips you will give to me as a pregnant woman during pregnancy for those 9 months to make sure everything that's on my part now? What should I be doing as the expectant mother?
So before I get pregnant, I want to make sure I'm healthy. I want to make sure I don't have anything that is unknown. And that's actually what we do in the first prenatal visit, when a woman is visiting a doctor for the first time. If they didn't come before pregnancy, at least want to catch everything that is going on at the time they are presenting for the first time. Do I have enough blood? Am I anemic? Do I need to work on that? Are there background viral diseases that I need to check out and treat? Are there anything like the hypertension, the diabetes, what's my age? We do what we call risk assessment. So risk assessment, there are criteria we look at and say, you fall into this category, and this is what we advise. On a general note, we want women to be on folic acid before they get pregnant. It has helped to prevent congenital anomalies, so be on folic acid or food that is rich in folic acid. There's a link with congenital abnormalities with folic acid, making it less likely to have that. And then decide where you're going to go for delivery, not only delivery, also for prenatal care. Understand in the principles of prenatal care, you may not feel ill. You may not need a doctor. Nothing may happen. And I will simply say the story of this young lady who had, she was well throughout her pregnancy. And then at 36 weeks, she suddenly had a headache. First pregnancy, headaches. She rushed to the hospital, I think she came a few hours later, and then her baby was dead.
Oh, no.
She's had hypertension. So hypertension is what does things like that. Like just quickly like that, it was all gone. So the baby was dead. And so second pregnancy, she came to the UCH then. And of course, these kind of people who've had those kind of experiences, you monitor them more frequently. So she was there every 2 weeks, she was in the hospital. We did everything we needed to do. At 36 weeks, she came in, she was fine and dandy in the morning. I saw her personally, and I happened to be on call that night, and she was wheeled in a wheelchair, same symptoms. Oh, no. She's coming in and she's having a headache. We did the fetal heart, it was still there. So we were not going to give a chance. So these are the things where we want to do cesarean section and somebody is saying, no, I want to think about it. We went straight ahead for cesarean section, and thank God we did, because she had what we call abruptio. So abruptio, the placenta had detached, only a small portion. Actually, the rim was what was holding that baby in. If we were 5 minutes later than that, she could have lost that baby again. Okay, so that's how dramatic hypertensive disorders are. This is not a pregnancy that you will say, I don't want to go to the hospital. If it means shifting base and go and rent a house near the hospital, if you are really, honestly, some things have to give when it comes to this kind of treatment. And look for a good doctor, look for a good hospital that will consistently follow you, make sure everything goes good as far as hypertension is concerned. On a general note, a woman cannot take care of herself. Always remember, this is teamwork. Yourself, the knowledge you know, what you eat, how you comply with medical advice, and choosing a person you trust and be able to work with that person. At the end of the day, we believe that all that combination would help to reduce the eventualities of hypertensive disorders in pregnancy.
Thank you. Okay. You also raised some points that will require further clarification. You mentioned only folic acid. Are there other nutrients, nutritional factors, minerals, trace minerals, and then vitamins, and maybe even macronutrients, proteins, and other things that can help a pregnant woman in particular during pregnancy to prevent congenital abnormalities and even preserve the life of the mother herself? Then I also want you to talk about postpartum blues that normally affects some women after they deliver, and maybe how that connects to their nutritional profile.
When it comes to nutrition, I believe that Reverend Tony will be a better expert than me. But on a general note, most of the time, what we say is the prenatal tablets contain much more than folic acid. It will contain iron, folic acid, zinc, magnesium, trace elements, things that a woman should have in correct proportions before they get pregnant. A woman who is planning pregnancy, and so I was kind of trying to relate it more to preventing congenital abnormalities and hypertensive disorders. On a general note, we want women who are healthy, both in body, like nutrition. We all know that food matters a lot. In those days, you think you could, and this brings me to another story. Okay, in those days in Lagos, I saw a woman, somebody, they sell multivitamins in the vehicles, I was in one vehicle and somebody was promoting this multivitamin. And then I saw this woman, she's pregnant, obviously pregnant, but very emaciated, like somebody who's not having enough food to eat. And she was the first to reach out to buy a very expensive multivitamin. And I'm like, there's something wrong here. So eating healthy itself is something that all of us, you want, whether you're going to get pregnant or not, you want to eat healthy, have all the micronutrients, particularly before pregnancy. When you're pregnant, food is first. But multivitamin comes in because many of our foods are processed. Many of our foods, if it's not fresh the way it's coming from the earth, like many of us don't even have access to that anymore, then we need to be cognizant of the fact that some of the micronutrients are gone, either from production or cooking or packaging. And so we need to supplement with those things to remain healthy and prevent some of these things in pregnancy, for sure. Now, talking about postpartum blues. So I'm trying to shift. Let me say an overview general impression that I have. I know that when it comes to having a pregnancy that is healthy and baby is multifactorial. Some of the things we have in Africa, people don't have it here. And that is the emotional part of it, the support. It really affects how someone will go through pregnancy. I recently wrote a book about my experience from South, African or developing countries where I practice, and here I see a lot of differences. One of the things is there's good medical practice, there's good medication if you want, there's good food, you can supplement, people can afford things. People don't die, but there's a lot of emotional issues here that we don't have at home. So I don't think we should dump one, we should learn from both. So when it comes to postpartum blues, it's a condition that has been recognized. It's probably more reported here. And people at home would have it too. But it's in my practice, I see that we have factors that can easily mitigate against that. We get a lot of support. We get a lot of help. We get a lot of things done. You talk of traditional birth attendants back home. We know they are not trained, but they care. And that's where people go to people who care, who they can trust. They would rather go there than to a doctor in white coat who just sits there for 2 minutes, writes some prescription and say, go away. So when it comes to childbirth, we need more than just the obstetrician who can do the cesarean section. We need all the support. So right here now in developed countries, I am one of those who is pushing for more culturally acceptable care, where we have what the technicality, but people still come down more with the postpartum blues, the depressions, the emotional things that just support in pregnancy can bring. And it brings me to that interesting part of people are now doing, there's a profession of being a doula, which is more like a traditional birth attendant, but they are not trained to deliver babies. They don't interfere with the medical cause of it, but they support like you've never seen it before. Like what our grandmothers would do in those days. They are there for the mom, they support, they rub the back, they do everything. And it has been shown that such women do so much better in labor. They need less cesarean section, they need less analgesia, and they do better postpartum with less of postpartum depression. So there are those dimensions also that I want us to see as a way of, we don't dump everything we do, we pool the resources together. Every woman needs both. You need the technical, the good hospitals, the good doctors and all that. You need the good support person. You need good knowledge yourself of where do I go if this was going to happen. I have friends that still call me here. This is happening. What should we do? Then I link up with, okay, you go to this place or do this, you know. Those are first that have a social network of people you can jump on last minute, something is happening, come pick me, you know, those kind of things. And that the things that really at the end of the day make for a healthy pregnancy and have healthy delivery put together and preventing postpartum depression.
Right. Thank you so very much. So at least I'm happy that in Africa, we have something that the rest of the world can also learn from. we do a lot of what we call omugwo right here. Once a woman puts to bed, you can be sure that the grandmas from both sides, from the husband's side, from the wife's side, they are all packing their bags. They're coming over, you know, to come and give all the support to the new mother. And so she's not overwhelmed with caring for that baby. It gives her time to also be able to rest and recuperate and get back to shape, you know. So we're going to go on a short break. And then when we are back, this conversation is getting more and more beautiful. We will continue after this short break. Don't go away. Thank you very much. Thank you. I'm so honored, and I want to thank you for being here today. Gentlemen of the press, ladies and gentlemen, on this great platform, on this special occasion, the table is set with all kinds of delicacies for your nourishment. You also have special wines to make and keep you refreshed. And I hope you're really hungry and very thirsty because there's so much to fill you to overflowing. You may be wondering, what is this platform? And what is the occasion we're talking about? Of course, I'm talking about the platform of DIS 2023, Divine Impact Summit, and the occasion of our anniversary and convention to celebrate the goodness of the Lord for 19 years of the Shepherd's Flock International Church. Come ready, come empty, and have your cup filled to the brim and even to overflowing with plenty, because it's our season of a mighty harvest. Ladies and gentlemen, it's vintage. I am Reverend Tony Akinyemi, and I'm inviting you to the platform where divinity meets with humanity, the Divine Impact Summit. God is committed to His word on harvest to perform it on the platform of the Divine Impact Summit 2023. It's almost full on the inside, so hurry and reserve a seat for yourself and someone you love. It's vintage, a season of mighty harvests.
You said you are going to do this and this and this through my life. They are not yet done, so it's not time. And the sickness that seems was going to kill me will just disappear. But if you do not engage your assignment, what will you tell God?
So the things you do triggers off something in heaven, and God responds to the things you do.
So there are things that if God forgets, He becomes unrighteous. And God says, look, I'm too holy to become unrighteous.
Welcome back. This is still Exposé with Tony Akinyemi, where we bring you wellness information for your health transformation. We've been interviewing Dr. Florence Kemi, the wife of Akindele, a consultant gynecologist, obstetrician, and a public health physician who has been doling it out, in quantum, as far as her experience in dealing with maternal mortality in particular. We've learned so much. We've been looking at the 5 categories of factors that could contribute to maternal mortality. We've dealt with 3 of them already. Because of the brevity of time, I don't want to go over them, but I believe that you already followed us. Now we have 2 more categories to deal with. The 4th category has to do with embolism, blood clotting and other things involved in that category. And then we'll look at sepsis as the 5th category. So she will start with embolism right now in talking to us about embolism as a factor in maternal mortality. Over to you, madam.
Thank you. So embolism happens in pregnant women or people who've just delivered just by nature of pregnancy. We call it an hypercoagulable state, which means the body is ready to mitigate against you having postpartum hemorrhage, and so releases a lot of blood clotting factors. So you can clot, and when there's clotting, there's also that chance of a clot being dislodged and going to the brain or the blocked major vessels, causing stroke and all that. So it's one of the things that causes maternal deaths. That's why I'm mentioning it. It's more common in the developed country, over and above the developing country, but it can happen anytime, anywhere. And it's also very dramatic. Apart from blood clots, there's what we call amniotic fluid embolism, which some of the amniotic fluid of the baby gets into the blood vessels and gets transported to the big vessels of the brain and causes embolism as well. But those are very rare, and it's just a matter of mentioning them. We've kind of tried to prevent that by giving prophylaxis. So some women have higher reasons for us, they are at higher risk. People who have weight, problems, BMI, large BMIs, and hypertensive disorders. So we do that, and we give heparin or in micro amounts. But it's something that we need to be aware of. And if we are at risk, please let the doctors manage it properly. Don't fate it.
All right. Okay, yeah. So we move on to the 5th one now, which has to do with sepsis as another category. So you have the floor.
Thank you. So the 5th one is not definitely the least. It's a big one in sub-Saharan Africa. It is puerperal sepsis. It is sepsis of any kind. And when a woman delivers under even septic conditions, she could come down with infection. So how much more where it's aseptic, where things are reused without proper sterilization, gloves that are used to attend to the woman, it's not sterile. They are the disposable ones. It's and also practices that could lead to puerperal sepsis. Now, because again, there's a large surface in the uterus that has just released the placenta, microorganisms can go there, and it's a big deal. It kills. That's one thing, using of aseptic techniques to deliver a baby. The second thing is antibiotics, the usage of antibiotics. When we use antibiotics for every little thing, when we use antibiotics, we don't complete the course, we don't know what it's about, we just use it anyhow. It then makes there to be many organisms that would not respond to those antibiotics anymore. And so we have to now go for higher antibiotics that are more expensive. There's the issue of fake antibiotics. There's the issue of, not even getting it on time. I remember a woman who had gone, so these things come in together. Woman had gone through labor at home, and then they took her to church and then brought her to UCH. The baby had been dead for 3 days. And it was so bad. but they didn't have money for antibiotics. It was in the middle of the night. We just couldn't even get antibiotics. All we could get was one type of antibiotics, which we flooded her with, and then we had to do the surgery to remove the dead baby. So a baby being dead for days and things like that would predispose to all manner of complications from infection. And then we don't then have the antibiotics to take care of it. So it's a major issue. Under that, I'm also thinking of, okay, so I'm sure some of my colleagues will be looking at me saying, she's not even talking about obstructed labor. Obstructed labor is real in Nigeria. But many times they come in not only obstructed, but septic with dead babies or near dead babies. So those are things that come out from prolonged labor. A woman is in labor. Ideally, any woman who is delivering a baby for the first time, who you are sure is in labor, should deliver within 24 hours. But by the time you are going to second day, third day, and you're facing it, go to hospital. I have found out, I mean, when people talk of, I had this song back in those days when they would say, may I never deliver with a knife.
Yeah.
Deliver with a knife, a nice baby, and a nice life. Yes, and be alive. So obstructed labor is big in terms of maternal mortality in Nigeria, or in my practice in Nigeria, because many people want to avoid cesarean section at all costs. And then there's infection that comes on top of it, and then that. Obstructed labor also causes uterine rupture, particularly for women who've had cesarean sections before. If you've had cesarean sections before, please don't take law into your hands to go somewhere else to say you want to prevent another cesarean section. That is one big thing that I've seen many women, Christians, die from. It is just, I don't want cesarean section. And if you don't want cesarean section, then go and be supervised properly while you're in labor, so that if you then need it, you want cesarean section, believe me, you don't want uterine rupture. You don't want to bleed from uterine rupture, and you don't want to die from this. So please, cesarean section done properly at the right place will prevent uterine rupture, will prevent maternal death, will prevent infant death, perinatal death. Women lose their babies just from not wanting to repeat. And so all these factors come into play. They don't want cesarean section. They go and deliver where the places we have untrained medical personnel, in quote. The babies get stuck. Then they run into problems of uterine rupture, baby is dead, they bleed, they get infected. I've seen a sickler who had to need hip replacement. She went to deliver, precious baby. She had looked for this baby. Then she went to deliver in a place that wasn't a hospital. And then she was brought to the hospital. The baby was dead. She had avascular necrosis of the hip. She was on bed with pain for so long. We don't want this. Faith doesn't produce this. What faith does is it gives us live mothers and live babies. Amen. That's my belief.
Okay. Thank you.
Okay, so I tried to overview everything together and package them to say, those are the other things that we talk about, but they are all linked to either infection, damage to structures that are, that could lead to like the uterine rupture, or hemorrhage. Okay.
You've mentioned a number of technical words that I know that our viewers will be saying, this is very, very big. Now, when they hear avascular necrosis, they're wondering, what is that one again?
Sometimes I find it difficult to break it down, but let me just say avascular necrosis is a condition that is common in sicklers. People who have sickle cell disease, they are tiny vessels that supply the organs easily get clogged with the sickle cell. And so those receiving organs don't get blood, and then they die. So for the hip of this woman, because of the positioning and whatever they did, she probably also had a crisis at that time. The blood vessels got clogged long enough for her to have the death of the head of her thigh bone, of her thigh bone. And so that hip joint, she couldn't walk with it. She would need either replacement of it, or she heals in a way she can't walk well going forward.
Okay. All right. Thank you. Now, let's speak to the issue of, do we call them maternity centers, or where people go to deliver? There are not hospitals, places people go to, even prayer houses and other places people go to deliver their babies. They say, no, I don't want to go to the hospital, or I can't afford the fee for the hospital in third world countries in particular. Now, what would you advise that a pregnant woman who needs a place to deliver her baby, apart from the home? We will still come back to home birth, but I want us to look at those who are not delivering at home now, who need a place to go to, but yet they can't find or they can't afford the regular hospital, or for whatever sentiment, they are saying, I don't want to go to the hospital. I just want to go to a prayer house. I want to go to places where they will attend to me. What should such women look for in a center before they go there? What should be in place? And what are the red flags they should see and run away and say, hey, this is like an abattoir and they are going to kill me here. Yeah. Right.
Thank you. So the number one thing that I would say is, depending on where the person lives, you go to a place where you want to have prenatal care. You pray, that's great. If the place is dirty, they can't even take care of their environment, and you're going to have a delivery there, you should think again. Number two, you go there, nobody does anything like blood pressure. Blood pressure is the basic thing that needs to be done. And if prenatal care will make sense. Like I told you, prenatal care came about because people are trying to prevent hypertensive complications in pregnancy. And so if you now go to a place where that is supposed to be picked and treated on time, and they're not even checking it, then you need to go somewhere. Either you go and buy one for yourself and bring it there, or whatever you want to do. So that's another red flag. They're not checking your urine. We can be educated, we can be informed about how to do these things. But if those things are not in place, and then you don't see, I know that many women want somebody who they can trust. But trust will be on two levels. You're praying and you are taking action that will prevent some of these things that we have talked about. It's okay to have prenatal care close home, but both of you can plan delivery elsewhere. You don't have to have both prenatal care and delivery. Once you see that this is not, so prenatal care would help us to put you in a category of whether you are high risk or low risk. Let me say this, over 90% of women will have their babies irrespective of place. They could almost have their babies on their own and nothing will happen. You know, God has so built the body. Nature will take care of the bleeding. Nature will take care of everything. But the 10% that we have problems, it's too large. That's the number that is too large. One is too many for a mother. If a mother dies, you know, it's affecting a whole nation.
Yeah.
It's affecting that family, it's affecting that community. So it's too much. So if I have proposed to people, do a job. People do a job because they want to have, you know, throw parties, or they want to buy something. To not die, you know, do it to have enough to be able to say, you look, where in my area, they don't even have a good hospital. I've heard that so many people die here. Okay, I am saving money towards my delivery. And then I'm not going to deliver here. So you have history of such places, such people, what has happened to women. Don't go there again because you don't have money. Please save money and go where you need to go. And maybe I'm talking about this because I know that on a governmental level, we are all shouting. I don't know how many radio programs I've done. Please, let's make these things available. But if it's not being, if it's not available yet, at least these are the things that I believe women can do. Women can read books, go on the internet. The internet now is well, again, we're talking of education. But, you know, as seen educated people. And this is another story. A woman was brought to us in UC at that time. She had delivered a baby. And, she had delivered a baby. She was fine. She had washed her clothes. She was spreading clothes and she fell down. And she was unconscious. And they brought her to us. She had a twin. There was another baby in her womb, and they did not know. The people who delivered her did not know. She didn't have prenatal care, and she was a teacher. So it's not about education. So these are things that happen, and you'll be like, how can that be? What that means is she never had an ultrasound in that pregnancy. She never had anything to do with, blood pressure, whatever. Everything happened after the delivery of the first one. And she was educated. So please, I just want to tell stories because I see both the faith part of it and the technical part of it. And I'm one person who has struggled with these things. I'm like, Lord, you have to teach me what does this mean to bring the two together. We can't do one without the other. I mean, doctors can tell you nothing would ever happen. You need your faith. When you go to hospital, you don't go without Jesus. You go with your faith or whatever. Just go there, get things done, and come out alive with a live baby at the end of the day. That's, for me, faith works that way. Bring that faith to bear in the hospital. And I've told people this. The hospitals still do most of treatments. When it comes to trauma, when it comes to obstructed labor, do the surgery, your life is easier. Amen. I don't know how to push this further than that. So you have prenatal care, please stay alive. No, this is a matter of life and death. You want to do savings, do savings. And I honestly, my heart bleeds for the number of quack practices, not just people who didn't go to medical school, people who also went to medical school, but don't keep updated when it comes to things about women's health and deliveries and all that. It's so important. Maternal mortality is one of the indices that will tell the world whether a nation is poor or rich. You can build all the edifices, but when you lose mothers, it's almost unheard of. Who takes care of those babies? We lose babies who have potentials to become anything in life and transform the whole nation. But we lose them anyway because we won't take simple precautions. So please, whatever we're going to do to stay alive, stay alive and let those babies stay alive, we got to start thinking outside the box. That's my submission.
Thank you once again. Thank you. Now, again, another statistics that you mentioned is that about 90% of women can have their deliveries normally. Nature will take care of them and they may not have complications. Nothing may go wrong. But there is a small percentage, 10%, that will need care, who belong to the high-risk group. Okay? Now, if we take a nation like Nigeria as a case study, let's assume 200 million people. 10% of 200 million is 20 million people. Let's assume half of them are women. That's 10 million women that belong to the high-risk group. Now, so 10 million is a significant figure. We have to think about how to save those 10 million from, dying from preventable death at the end of the day. That is one. Then talking about the issue of CS, I will not deliver with a knife. I can recall an experience I had as a young pastor. I just came out of school. I was a young pastor. And then I was invited to come and pray, come and do a naming ceremony for a particular, couple. They just had their baby. They went abroad to have the baby, and then they came back to Nigeria, and they said I should come. And they were not attending my church, but, they didn't have a church of their own, but they just wanted a pastor to come and name the baby for them. And so their neighbor, who knew me very well, was the one who invited me. I was very eager to go and render that service, so I went. And then I was praying for the family after the naming, and I was thanking God that God, you did not allow them to use a knife to carry out this baby. I didn't know that she actually delivered by CS. It was after the naming ceremony that The grandma called me aside and said, actually, she delivered by CS, so we should be thanking God for the success of the surgery. I mean, I was a rookie. I was just a greenhorn in this whole thing, but I thank God we now know better. We are all growing and understanding better and better by the day. And we know that there's actually nothing wrong in delivering by CS if you have to. And then talking about savings, you also mentioned a very critical one there, that people can save towards their delivery as the same way they save to do other things. Now, I have also noticed in this part of the world that people will tell you when you ask them to go to a very good maternity center or hospital or delivery home to deliver, they will say, no, I can't afford the fee. I don't have the money. And then they will do everything to deliver by themselves or go to the wrong places to deliver. And now, when the baby is born and they want to christen the baby here in Nigeria, they want to do naming ceremony, you will now see the party they are throwing. The same people that told you they didn't have money to go to a good hospital, come and see how they will roll out the drums and they will kill goats and kill cow and begin to feed everybody. And it makes me to wonder, where does your priority lie? At the end of the day, so I think we just need to start, resetting a number of things in our psyche and our mentality and mindset and just correct some of these anomalies within. It's a very, very important one. We will round off with this last portion. I want you to address this one. What are the issues to be considered when we're dealing with all of these problems you have mentioned, vis-a-vis the various levels of care, primary care, secondary care, tertiary care? What roles do these levels, at each level, what should each level be looking at as their contribution towards, addressing all of these problems together?
Thank you. I think the biggest role will fall in the lap of the primary care, because the primary care is that care that should be inexpensive, close to homes. Like you just have a place where somebody who is knowledgeable is doing blood pressure and pee. That's all. Like you don't need all the gadgets. In a way, in Nigeria, I've seen many of us do all of it together. And so we struggle. So you want to have private hospitals work like primary, secondary, tertiary. I think it's going to be a novel idea for private or church institutions to have just primary care. Just primary care. We don't do deliveries here, but we teach you. You get people who are passionate about what they do, who will tell you your case, who will be able to categorize into the risk. Let me quickly say this. Even for women who are expected, who are low risk, things could go dramatic quickly. That's why people just need to know. They need to hear stories. They need to be told, you can actually do this. And so when you have primary care maternity centers, they don't do delivery. All they do is prevention. You are eating well. They make sure you are your blood pressure is monitored. You do the basic test, CBC. You are taking your good food and all that. And they advise you strongly. They will tell you, in this whole area, we've looked at hospitals, your best bet is to do this. If you can't afford it, you can save. See, that service is missed. I think because churches do deliveries as well, we kind of plump everything together. I think churches can do prenatal care, like really care for those women and give the information of what they need to do and where they need to go. So primary care does the preventive aspect, the nutrition, the education, the categorizing into risk, the picking up of things that could be a problem later. That's all under primary care. According to WHO, it's supposed to be accessible to every individual in a nation. And I think that is possible. Now, secondary care is where you now need the delivery, the aseptic techniques, people who are trained, and the availability of, so access is still under primary care. So, for instance, let me put it this way. There's a woman in this neighborhood who is pregnant for the first time. We've never tried her pelvis. We don't know how she will perform, but she gets access to people who every month they're checking her blood pressure. She trusts them. By the 7th month, they are telling her something has to be done about your delivery. Even when she starts, you can start saving. These are the people die from this. We don't want you dead. We want to help. We want to do this. Then they take her. If she needs secondary care, if she's one of those who is categorized as high risk, she gets help and money to go for that. So secondary care means there's availability of childbirth facilities, and we categorize them here into 1A, 1B. 1A means you can deliver babies low risk. 1B means there's cesarean section facility, simple cesarean section. And then we now talk of the higher ones, which are the tertiary, which if the 1A, 1B categories find that there's a problem, there's easy transport to those facilities that can handle the complications. Oh, somebody now has a preeclampsia, somebody has diabetes, and the baby might be big, or the baby, they have higher risk of stillborn. You can transfer. So the robustness of the systems of operation. So where you have low risk pregnancy women who are taken care of at the primary care level and are able to be transferred to the secondary care, or women who already have identified risk and you're able to transfer them to the tertiary care, that flow helps any system. Where you have people who have low risk pregnancies who would but can afford it, they're the ones that go to the tertiary. The primary level is left unattended to because everybody seems to think going to primary care means you don't have money. That is not the issue. It's about the health and the system. So if you have the tertiary care loaded with people who have primary care problems and no space for the transferred in, because that's what I saw back home. At the tertiary hospital, you have a lot of people come in, deliver normal babies. The ones that need us come late and come without money. So that brings me to another story. A man brought his wife who has delivered a baby and was at hemorrhage. Placenta was still there 2 days after. Delivered at home, went to church, went to a private hospital. They couldn't deliver the placenta, and now brought the patient to a tertiary hospital where I was working. And there we said, look, we need blood, we need money to do the surgery. He said, no, he doesn't have money. I was overhearing. He said, discharge her, I'm taking her home.
Oh.
With the placenta, because he didn't have the money. And then I came out and I said, excuse me, what work do you do, sir? He said, oh, I'm a driver. I said, God forbid you have an accident. If you had an accident and you were bleeding to death, this woman will sell clothes. She's going to run around. She's going to go to her neighbors. She's going to do everything to save your life. So you can't do this for her. She just had your baby. The man looked at me and said, okay, please continue. I will go and look for the money. And he did look for the money. He did. So I think there's something about being able to relate with the problem, relate with the social capital, make a system work from primary to secondary to tertiary that we need education about as a nation or as a group of people. And not just focus on one person's primary problem. On a policy basis, there should be a robust atmosphere of primary care for pregnant women. It's not expensive. And I think, honestly, many mission houses, that's what they should be doing, not delivering the babies, not trying to do cesarean section. Let's focus on preventing these deaths for a large number of people. And let whoever would then come up with good hospitals, good resources. Don't do things, cut corners. We do a lot of cutting corners, and it costs people their lives. So why don't we put resources where it's needed most? It is the primary, I believe, that is needed most right now. And then people can graduate and begin to do better things, both secondary and tertiary.
Right. Now, a lot of sociology, a lot of psychology, a lot of economics, all of them have come to play right here. For example, you were talking about private hospitals in a place like Nigeria rolling all three into one. They do primary, they do secondary, they do tertiary. Now, I am thinking, I may be wrong, I'm thinking economic factors play a big role in that, because the hospital wants the bottom line, they want to make more money, and they want to corner as many opportunities to make money as possible. Now, don't you think it should be government that should formulate policies that will regulate the industry?
Definitely. Governments, see, even when we talk of preventing maternal deaths, I always love to give personal stories. When I was home, my passion, and I talked to some of the political leaders then, my passion was to see maternal mortality registered, notified. I went to a state commissioner and said, sir, you are my guy. Really, please, I want you in your position to do this. Make sure that deaths are notifiable under law. So the fact that a woman dies is not why somebody will be punished. Nobody needs to be punished. It's not a punishable thing. It's a complex. But notify us. Tell us a woman died at home, in school, wherever. This woman is dead. Then we can look at why. That's how people in the UK, there were a lot of maternal deaths. If you look at some of the movies or this Call a Midwife, you see the conditions they were also delivering in the 1940s. And it was horrible. But then they took it that, okay, we want to know why. So they started from there, and now they are where they are. So we need to know why. Government needs to put up policy. I'm not even saying policy about, okay, if you did quackery, you are going to jail. No. Tell us a woman died and give us the permission to find out why and make it not punishable that a woman died.
You can prevent.
Exactly. Otherwise, people won't notify. But the punishable thing is a woman died and you didn't let us know. Then we can take it from there. So, like you said, the policies should come from the government about what a private hospital can do and all that. But it's all mangled up. And so in my own thought, I'm thinking, okay, if we start from the primary, where even churches, missions, places can be well tutored on how to manage such, simply, inexpensively, to attract a lot more women, to give them the knowledge. Perhaps the larger the number of women that are now talking and with all the politics, something will start happening in the hospital. Because it's frustrating to keep seeing the same problems over and over again. And you say, okay, government should do something. And we've tried for so long. And you're like, okay, at least if government won't do anything, save your life, woman. You too, do this and do that. It has almost come to that, Let the families be involved. Let the husbands be involved. Let people know that it's good to save. It is not the naming ceremony that matters. It is the care of that woman in pregnancy. So that there can be a naming ceremony at all. If you guys, there's no naming ceremony. Well, I guess some people say they still do naming ceremony. So that's my own thing about it. I think we need to think more robustly about primary care. And then maybe perhaps when we handle when a woman behaves very ignorantly, you will be like, okay, at least this one could have been saved. From that, yes. So I think a lot more of the maternal deaths that are going on back home, if I still relate with what's happening, it has to do with the economic factors, but many of it has to do with ignorance and fear instead of faith, and all that. So that confusion, even if that's the only thing that can be addressed, it will save some women. And then we leave government and pray for them to be able to effect the policies that they should to save more women. And then the tertiary can come up after that, because it's actually very expensive to do primary care because it's broad. You can have many of these kind of centers in 1 million places, for instance. You're trying to save 10 million women. Why can't you have it in 1 million places?
Right.
Yeah. So that's the whole idea.
I want, because of time now, I want us to tie it up here. You mentioned the fact that churches, mission houses may have, some definite roles to play. I want you to address two areas. If you were to serve as a consultant to my local church, for example, I'm a pastor, and you want to serve as a consultant to my local church, consulting for us to advise us on how to package something along this line that is within our purview to render as part of our own services to our congregants and indeed anybody in the community that wants to take advantage of those services? What would you recommend that we put in place? That's one. The second part is, are there places that personnel can be trained to serve in those centers? Or are there people who already have some certifications in some areas that can be, employed to serve there? Or are there specialized trainings that you can just send anybody with a requisite education to go train and then come and serve in that particular unit in the church?
I am aware that at some point the Nigerian government was training certain traditional birth attendants.
Good. Sorry to cut in. I want you to take it along with the home delivery thing that we left out the other time. Just add everything. If somebody wants to, all right, go ahead, please.
Okay. So the Nigerian government was, we were training traditional birth attendants, people who are popular in their areas. They didn't want to punish them or anything. They wanted to say, okay, have access to aseptic techniques, give them gloves, don't use, and all that. Those are basic trainings that will save some women, because no matter what we're saying now, some women are not even hearing this. They don't have access to the internet. They don't have access to phone, whatever. So it will still be those women that will deliver them, because people get pregnant anywhere. And so if those women can at least know the basic things of aseptic techniques and pick up signs when they see them and send them appropriately, to some women will still be saved. Even though that's not ideal, but that's what we got. And now talking about home delivery, I was just telling Reverend that here in Canada, people are more tending towards more naturalized birth. They want to birth at home. Actually, my book that I wrote, a patient came to me and said, I want to deliver like an African woman. And I'm like, I'm looking at this Caucasian woman. I'm like, you want to deliver like an African woman? She says, yes. I said, what's your impression about African women? He said, they are strong. They deliver their babies without all these technicalities and all these machines. Many of us want to go back to the roots, which means they want to be home amongst their family. Now that there's infectious disease, COVID has just gone, you can't come to the hospital with your family. There are stories I have of that, of my experience during COVID. But ultimately, women not only want safety, they want comfort when it comes to delivering babies. And that's where you now get to places where there's almost no maternal death happening. We've overcome the biggest evil. So now people want to go back to the roots. They are well educated, they've eaten well, they can afford to have somebody, a midwife, come sit with them at home while they have their babies. Why not? So that's the reward of dealing with the big problems first. We're not dealing with safety here now. We are talking of comfort. But back home, we're talking of safety. We're talking of let these women stop dying first. Then we can talk about, the other part of it. So maybe that's just a little one along that side. Now, before I lose my train of thought, the first question was, I'm trying to wrap up here now. You are talking about a first question before I started with the second one.
Yes, the first question has to do with you serving as a consultant to my church to set up a unit.
If I was going to set up a unit, so this was one of the things I did when I saw the problem in UCH then. In my church, any woman that got pregnant, we had these meetings like once a month where I personally taught what I call prenatal classes. In addition, so that in those places, what we can do, I see as a church, is to also have volunteers mainly of personnel, medical personnel, who will come maybe once a month. You do a roster, there are 12 personnel, one person come once a year. That's fine. It's just to check the blood pressure, make sure this person is fine. Make sure that, okay, which hospital do you go? What test did they do? What did they tell you about the risk? Did they even, talk about risk and where you're going to deliver safely? Can you afford it? Then the church plays that role of, we're doing care, not taking over the care of the hospital. We are putting in the missing link of getting this woman to understand that it's a risk to be pregnant and what they can do in terms of nutrition and all that, and getting access to care. you want to know which hospital exactly are you planning to deliver. I went to deliver a lecture in a church sometime, and I talked about these issues. And then one woman ran after me afterwards and said she was pregnant. She said, this pregnancy was conceived by prayers. I don't intend to go and deliver in a hospital. I waited for, I don't know, maybe 10 years, and now I'm pregnant. You know what I did? I just took her hand and I took her to the pastor's wife. And I said, this woman must deliver in a hospital. And she's looking at me. Then I sat down and explained why. And of course, the pastor's wife took it up to say, yes, we will make sure that happens. And I said, when that happens, let me know when she has delivered her baby safely. So what am I saying? That the church can have influence on how the perception of women. So if we have this kind of what I call clinic, just for mothers, you're pregnant, feel safe to come there. Nobody's going to force you to do things. We're going to educate you. We're going to make sure you are linked with the right group of doctors or nurses and ensure that you have a normal delivery. I think that's what I would do as a consultant to any church who is interested in helping mitigate against maternal mortality. It will go a long way.
Thank you very much. Actually, we have something similar in our church. We have our medical personnel, the doctors, the nurses, the pharmacists, all of them are there. And but I know we can put more structure to some of these things. And then there's also the aspect where even the patients themselves have a lot of sentiments and reservations here and there. We need to also work on that as spiritual leaders, church leaders, to kind of, break down all these barriers in their minds, mental blocks and all of that, so that we can all be on the same page and work together to reduce the statistics for Africa. I'm waiting for that day when maternal mortality in Nigeria will be less than 5 in 100,000. So before we let you go, would you please let us know how we can access some of your resource materials, the books you've written and what have you?
Yeah, all the books I've written are on Amazon. The last one called Your Joyous Birth Experience, empowering women to participate in their own labor and delivery. It just spans my experience from Nigeria to Canada, stories about births and what we can do to go better prepared for delivery.
So Amazon.com. If they just put in your name, your books will come out.
If you put Kemi Akindele, it will bring up all of my books on family matters, actually. But this Joyous Birth Experience, I'm trying to be Canadian as well. So it has Florence. It has the way it appears is, you can Google Florence Kemi Akindele to bring out that book.
So thank you very much for your time, for your expertise, for your knowledge, for your wisdom, and for your communication skills in making it very practical, very real. We appreciate you for your time. We know you have surgery to go perform any moment from now, so we'd like to let you go. Thank you very much for availing us this opportunity. So viewers, this is how far we have gone. We have overshot a little bit today, but that's for a reason. We want to squeeze as much as possible from her before we let her go. Thank you for spending your beautiful Monday evening with us. Do enjoy the rest of the week. Bye-bye and God bless.
You said you are going to do this and this and this through my life. They are not yet done, so it's not time. And the sickness that seems was going to kill me will just disappear. But if you do not engage your assignment, what will you tell God?
So the things you do triggers off something in heaven, and God responds to the things you do.
So there are things that if God forgets, he becomes unrighteous. And God says, look, I'm too holy to become unrighteous.